Hello, everyone. My name is Kim Lavoie. I'm a professor of psychology and behavioral medicine at the University of Quebec at Montreal and co-lead of the CBITN with Simon Bacon. And it's my real pleasure to be here with you today to present to you a module on assessments in behavioral trials with a focus on how do we assess treatment fidelity. So this is our brief land acknowledgement. Of course, CBITN depends on traditional Indigenous territories to provide us the physical space, sustenance, safety, and community to work, live, and play. And we acknowledge that our ability to live, work, and play on these lands is a direct benefit of policies of expulsion and assimilation of Indigenous peoples during the time of settlement and confederation. And so we want to acknowledge these harms and recognize that they're still being felt today. And we want to express CBITN's commitment to addressing and rectifying these harms in all of our work moving forward. These are my disclosures, but of course, there's nothing related to the content of this presentation. So the objectives of the presentation today. So by the end of this session, I expect and I hope that you will be able to recognize the importance of evaluating treatment fidelity in behavioral trials. And I want to help you identify appropriate methods and tools for assessing treatment fidelity. It's a really important outcome. So let's start by examining what is treatment fidelity. Well, it's the methodological strategies used to monitor and enhance the reliability and validity of behavioral interventions. And it's the methodological practices used to ensure that a research study reliably and validly tests a clinical intervention. But really, it's sort of in a nutshell, was the intervention administered in your trial as you had intended or as it was designed to be administered? So why should we care about treatment fidelity, the extent to which our interventions are delivered as planned? Well, questionable internal and or external validity makes it impossible to draw accurate conclusions about treatment efficacy and impossible to replicate a study. So what does it mean if you have a negative trial? If you haven't assessed treatment fidelity, it means you have a potentially effective treatment that may be prematurely discarded. So if you have a negative trial, but you didn't actually measure what people did, well, maybe it's negative, not because of the intervention not being effective, but because it wasn't administered in the way that you had designed it to be administered. What does it mean if you have a positive trial? Well, it means that a truly ineffective treatment may be implemented and adopted at a high cost to patients, providers, and the healthcare system. So it's really critical to know if your intervention was delivered in the way that you designed it to be delivered, okay? Because whether it's positive or negative, we really can't draw any confident conclusions from that result. So why does interventionist fidelity matter? Why does what our interventionists are doing in our trials matter? Well, it preserves internal validity against type 1 error, which is when we find a significant treatment effect, but which arose because unintended treatment ingredient was added to the intervention. It also preserves internal validity against type 2 error, which is when we find no treatment effect, but the treatment wasn't actually administered as intended, as I mentioned before. It also improves power, or something called research efficiency, by reducing unintended variability in the treatment effect. So these are the main reasons why interventionist fidelity matters. It also allows replication, dissemination, and implementation in practice, which is really, really critical. If we don't know what our interventionists actually did, we can't replicate the study. So why does participant fidelity matter? So this is now moving away from what did our interventionists do in our trials, but what did the participant do? Because most of the success, excuse me, in our behavioral interventions depends not only on what the interventionists do, but on the participant fully engaging in the trial. So different levels of participant fidelity. Well, did the treatment, was it received and comprehended by the patient? In the case of pharmacological trials, the equivalent would be, did the patient fill out their prescription? In a behavioral intervention, were patients conscious? Did they attend the treatment sessions? Did they access the web-based program if you had a digital intervention? Did they receive and read the pamphlet or other written materials? Did they comprehend what they read or interacted with? Could they read? Did they understand the material? Did they learn the skills that they were taught, and can they perform the skills? At the level of enactment, Did the patient use what they learned in the intervention in their daily life? Did they take the drug? Did they practice the skills? So not only was it effectively received, our interventions, but did patients do what they needed to do in reaction to that? So to illustrate some of the problems with not measuring fidelity or not knowing the fidelity of a treatment, I'd like to share a little example with you. So this is a study that was published a few years ago. It's an osteoporosis telephone intervention to improve medication adherence. And this is in patients with a new prescription for an osteoporosis medication. And the intervention was essentially a motivational communication or motivational interviewing intervention. And they randomized just over 2,000 patients to receive motivational interviewing by phone or to education. So, excuse me, the education in this case was the comparator condition. And all participants received a mean of 8 calls with an interventionist that lasted about 14 minutes each. And as I mentioned, they enrolled all patients with a new prescription for an osteoporosis drug. And the primary outcome was 12-month adherence to that drug, measured using something called the medication possession ratio. And that's essentially what proportion of time did patients have in their possession their medication for osteoporosis. And this prescription basically needed to be filled every month. So if you took it as prescribed, you would have been expected to fill a new prescription every month. So for example, the medication possession ratio, if you filled your prescription every month for 12 months, would have been 100%. If you only filled 6 out of 12 prescriptions in the course of a year, your medication possession ratio would have been 50% and not very good. So that was their primary outcome. So what did they find? No difference between our MI intervention and our education arm. So this was essentially a failed trial. So the conclusions were that motivational interviewing was actually not efficacious for improving medication adherence in this context. These are the actual percent adherence rates at 1 year. So we did see a slightly improved, better adherence rate in the MI group at 49% compared to 41% in the education group, but this was not statistically significant. Slight trend there in favor of MI, but this was not statistically significant. So the authors concluded that MI was not efficacious for improving adherence in this population. So what happened? All right, so to understand what happened, because we have to consider, is this a failed intervention? Like, is MI really just not effective for improving adherence? Or was there something that maybe went wrong at the level of the intervention delivery within the trial? So let's take it apart a little bit. So let's take a closer look at the MI intervention itself. So this comes straight out of the paper. So each session had a specific educational topic. So remember, there was 8 calls on average, and they discussed things like medications with your physician, calcium and vitamin T supplementation, fall prevention, managing adverse effects. So these were the educational topics each one covered during a session. And it also included a series of open-ended questions to elicit subjects, or in this case, participants' attitudes towards medication adherence and to determine barriers to long-term osteoporosis medication use. So the sessions seem to cover predetermined educational topics, and they used open questions to determine attitudes and barriers to adherence. So some red flags here for someone who has specific expertise in these kinds of interventions. Usually in MI, we're not covering completely predetermined educational topics. That's great for an educational intervention, but it's not really aligned with the skills that we use when we're doing motivational interviewing. Using open questions, of course, is something we definitely use in motivational interviewing, but not just to determine attitudes and barriers to adherence. Open questions is often used to develop discrepancies between patients' current behavior and their treatment objectives or goals. So even though they were said to use open questions in this intervention, which is MI, or could be within the context of motivational interviewing, I'm already not too sure if they use them in the right way. So we'll come back to that. Let's look at the comparator conditions. So their comparator was education. And interestingly, all patients received in this group received all the same educational topics that they covered in the MI group, okay? So what this says to me is that there was a good amount of overlap in intervention content. So both groups received essentially the same amount of education on the same topics. The only difference so far seems to be using those open questions to elicit attitudes and barriers, okay? Which is actually more assessment than intervention. So now let's look a little closer at the training supervision of the interventionists, so who actually delivered the MI in the study, and the extent to which they actually did MI. So what's interesting, you'll see in this little excerpt from the study, health educators receive training in motivational interviewing through a half-day training program at study initiation that include role-playing, lecture, and discussion. The MI counseling was reinforced through telephone conferences 1 to 2 times per month with a behavioral scientist and clinical expert. In addition, 3 times during the course of the 2.5-year study, health educators recorded client phone calls that were then reviewed and graded by a motivational interviewing trainer. And trainers gave structured feedback to health educators using an assessment tool. So the things I want you to kind of pull out from this is that health educators who were presumably MI naive going into this trial received half a day of training in MI. Now, for those of us who do MI, this is woefully inadequate to achieve levels of competency in doing this. It's a great introduction, but I would be very skeptical that they were able to demonstrate levels of competency in MI after only a half day of training. If we look now at the MI supervision, we'll see that they received 1 to 2 times per month with experts and got feedback on 3 recorded sessions. But details about the quality of what they heard, on the tapes, what kind of feedback, what kind of problems were the experts noticing when they reviewed the tapes? How many times did they have to kind of go back and intervene with the interventionists? We really didn't get a sense of that, at least it was not reported in the study. So in terms of treatment fidelity, what was really nice was that they said they recorded 3 sessions, and it was, graded using an assessment tool. However, they didn't report, well, how good was it? how well did the interventionist do in terms of the administration of MI? So they didn't report this. So there were many flaws in study design and reporting, I think, in this study. First of all, the MI intervention included education and asking open questions about attitudes and barriers, but education is not a core MI principle, technique, or skill. And the only MI skill used was asking open questions. They didn't report using any of the others, like reflective listening, developing discrepancies or discordance between behavior and outcomes. I'm also not sure that they used open questions in the way that MI wants us to use them. So they sounds like they use them to assess attitudes and barriers, but then what did we do with that information? So I'm not sure that they use open questions in the way that most of us would use it in the context of MI. They also didn't assess any, what we might call motivational interviewing mechanisms of change. So MI is really used to strengthen motivation and self-efficacy to change health behaviors. But did motivation or self-efficacy improve in the patients in this trial? That wasn't measured or reported. And as I mentioned, each educator recorded 3 sessions and received feedback, but the authors didn't report back on how well they did. So was there good fidelity to the MI intervention? Did they deliver it as the authors intended? We have no idea. So what we did with this, myself, Simon Bacon, and Tavis Campbell, is we wrote a letter to the editor asking, kind of commenting on our reflections to this paper. And, we asked them, given that 3 patient sessions were recorded, we said we were surprised that the authors didn't verify the MI treatment integrity or fidelity of the intervention, despite the availability of tools and recommendations to do so by consort. And so we said, because of this and other design flaws, we think it was premature of this group of authors to conclude that MI was not efficacious to improve adherence in this context. And we hope that our comments and constructive comments were really meant to encourage better designs and honestly editing in the future. So I just want to encourage you all, in light of this information that we're sharing with you through CBITN, not just this module on fidelity, beyond anything, we just really want to encourage you to kind of be little, CBITN soldiers, and really go out there with, when you're reading your intervention trial papers and studies, read them with a critical eye. And one of the questions I really want to encourage you to ask is, what was the interventionist's fidelity to the treatment? What did the authors take the time to measure and report? And if you're not satisfied, that should be a red flag that we can't really have confidence in the results of that trial. And I want to encourage you to send a letter to the editor. It's a great way to get publications, but it's also a great way to really constructively educate not only the authors of the intervention and trial, but also the editorial board of the journal, who obviously published the paper despite these important design flaws. So please feel free to do that and make us proud. A biased scientific result is no different from a useless one. So again, unless we really know what was actually done at the level of the intervention in the trial, we really can't interpret any results with confidence. I want to encourage you, therefore, to see the consort statement, the non-pharmacological trial extension, which has special provision for at least 5 extra items that you should be reporting. You want to be reporting on the training of your treatment providers, what supervision you gave your providers. Did your providers have any treatment preferences? And did the patients have any treatment preferences? So if you have 2 groups, intervention group and comparator, and let's assume it's an inactive control group, a waitlist control group, or a waitlist control group. Patients might sign up for an intervention trial because they want the intervention. They want to get the diet intervention. They want to get the physical activity intervention. So if they have a preference going in and they are assigned to the comparator condition where they're not going to get the intervention, this might actually undermine their adherence to not doing anything. So this might, encourage them to go out and exercise on their own, which of course, if they do that, which we can't prevent them from doing, but if they do that because they preferred from the start to be assigned to the intervention group, well, that means they're going to go out and do physical activity, which is going to unfortunately contaminate our 2 groups and reduce our ability to detect a significant effect for our intervention compared to our comparator. So measuring patients' treatment preferences or allegiances is an important thing to measure in our trials. Of course, treatment integrity or fidelity, as we've discussed so far. So how are we going to test that our interventionist delivered our intervention as intended? And treatment adherence. So this is at the level of the patient. So did the patient show up for the sessions? Did they engage in the sessions? Did they do the homework that was assigned? Did they practice the skills that we asked them to practice? Did they complete the outcome assessment? So these are different measures of treatment adherence. So we're going to end this presentation discussing methods of enhancing treatment fidelity at multiple points, because as I mentioned, fidelity, you can measure it at the level of the interventionist, at the level of the patient as well. So in terms of some study design considerations, and this comes to us from one of the readings I assigned, I think it's the Belge reading, if I'm not mistaken, where they have these really nice summary tables of different ways in which you can measure fidelity. These are some study design considerations that touch upon fidelity. So, the more you explicitly identify and use a theoretical model as a basis for your intervention, this will ensure that the intervention components and measures are reflective of the underlying theory. So there's a greater alignment between your measures and the theory upon which your intervention was based upon. I'm not going to read all of these. I'm just going to highlight the ones I've underlined. You want to determine ahead of time the number, length, and frequency of contacts between your patients and your interventionists, and develop a monitoring plan to maintain consistency in dose. What happens if they're supposed to get, 12, 30-minute sessions and your interventionist is just really enthusiastic and gives them twice as much time at each session? Well, this can undermine, the integrity of your intervention and bias it significantly. So you want to develop a plan to record protocol deviations. This might happen. So there might be a particular case where patients just need a little bit more time with you and you can't be completely rigid. So that might happen, but if it does happen and you have to deviate from your protocol, note it. So that way we can interpret it and consider that deviation when we're interpreting our results. Always want to encourage developing a user-friendly and scripted curriculum or treatment manual, something that all of your interventionists can use and refer to help keep them on track with the administration of your intervention. So, here are just, like I said, some study design considerations that you really need to think about ahead of time before you're ready to conduct your trial. And in terms of considerations for interventionist training, I've highlighted some things that I tend to do whenever I'm doing an intervention trial. Hiring. So when I am hiring research assistants or interventionists, I try to hire people with a certain set of credentials or experience. This way, all I have to really train them on is the protocol itself, but not the intervention I'm trying to deliver. So in the past, I've done many motivational interviewing, communication, interventions. So I tend to try to hire interventionists with clinical and relevant expertise in MI, so that all I'm really training them on is how to deliver MI in the context of my trial. I always standardize training in my treatment protocols. So that means, giving them a training in how to deliver the manual, how to record those deviations, training providers together, giving them access to the same, video or audio tapes, a support training. So again, making sure all my personnel get exposed to the same training. Before I will let an interventionist, quote unquote, loose in my intervention, I'm going to assess skill acquisition. I'm going to make sure that they meet a minimum level of competency in my intervention skills or whatever it is before I'm going to let them be an interventionist in my trial. Now, treatment delivery considerations. So this is the classic Fidelity. How are we measuring if our interventionists actually delivered our interventions as intended? Again, always use a scripted treatment manual if you can, and this again helps minimize deviations. You want to ensure adherence to your protocol by your interventionists in terms of what content they're delivering, how much of it they're delivering, and the process by which they're delivering it. So I always audio or videotape encounters. I usually probably more have relied upon audio recordings because they're more discreet, less invasive. I also actually ask providers to give me their own impressions about how well they adhere to the protocol. So I get self-reports, but also objective measures of what was actually delivered. And I will get those evaluated by at least 2 raters to make sure I have sort of independent corroboration that indeed my intervention was delivered in the way that I had intended. As I mentioned in my previous slide, establish minimum competency levels for your providers. That can often help ensure a high quality and standardization of competency across your providers. Makes things much easier. And finally, at the level of the patient, these are treatment receipt considerations. So at the level of the patient, what are they receiving? So you may want to administer some sort of assessment of, did they acquire the knowledge that you taught them? Were your materials culturally relevant? So in other words, if you have a very diverse population, you have to consider, how different populations like to learn, how they like to receive information. Is it better administered using more pictorial, more, photos of things, of information rather than text? You want to pay attention to different cultural values that might be important to respect. So these are things that, you might want to consider when you're measuring the extent to which your intervention was well received by patients. Another thing I often do is assess patients' confidence in the ability to apply the skills that I'm teaching them. most behavioral interventions involve skill building of some kind in patients. And so it's really easy to kind of stop short at just teaching people how to do things. So how do we self-monitor? So I might teach a patient how to record their blood pressure, or how to record their mood, or how to record their diet. But before I set them off into the wild, I'll say, okay, I've taught you a lot of things, how to interact with the trial materials and self-monitoring log, but I'd like to know, how confident are you in your ability to actually interact with these materials and do the self-monitoring on a daily basis? Do you foresee any barriers or any difficulties that, maybe we could address early? So again, these are additional things that you have to think about upfront when designing your intervention trial. And because there's so many things, along the pathway to change that we have to measure in behavioral interventions, that's not quite the same for pharmacological trials. So I'm going to give you, to end this presentation, a concrete example of how I've incorporated many of these Fidelity assessments into a trial I did several years ago. So this trial was called the Fisacto study, and it was a study funded and led by Boehringer Ingelheim, which is a pharmaceutical company. And it was designed to evaluate the effects of bronchodilation alone, which is a medication that is meant to open up the airways in the case of chronic obstructive pulmonary disease, the effects of bronchodilation alone or with exercise training, on exercise capacity, which was the primary outcome, and levels of physical activity done during daily life, which is the secondary outcome, in patients with moderate to severe COPD. So what this was a very complex intervention. It had 4 arms, 2 drugs, plus exercise training, which is ET, which is classic pulmonary rehab, teaching people how to exercise in a structured setting. 2 drugs without exercise training, 1 drug, and placebo. And every arm received SMBM. So what's SMBM? It was a behavioral intervention. So all patients in all 4 arms participated in a 12-week behavior change program focusing on improving patient engagement in the trial and focusing on getting them to do those daily steps, okay? So it was 6 sessions targeting physical activity, 2 individual sessions, 1 at the beginning, 1 at the end, and then 4 group sessions in the middle. And it was an intervention, a behavioral intervention, based on the Living Well with COPD program, which is a very well-established, internationally recognized behavioral self-management support program for COPD patients. And what we did is we took that well-established program and delivered it using a motivational counseling or interviewing style, okay? All study sites involved in this project were trained by the same behavior change experts, so that was me and my team. And implementation fidelity, so the extent to which the trial was actually delivered as intended, was monitored throughout the study and feedback was provided as needed. So just to give you a sense of the complexity of the intervention, this study was conducted in 11 countries, North America and across Europe, and in 8 different languages. So in terms of assessing fidelity and the extent to which this intervention was delivered right by everyone was quite challenging, okay? But I really want to thank the sponsor, Boehringer, for giving us the opportunity to implement this intervention in the trial in the way that we intended, including incorporating all of our fidelity assessments. So what did we do? So we started with the selection of interventionists. So imagine we've got 11 countries. And so I wanted to make sure people came into the study with minimum qualifications to help patients better self-manage their COPD. So we had a qualification questionnaire. Then we standardized the intervention protocol across the sites. We developed very detailed reference guides for all the interventionists and all the sites to refer to that very well detailed the content of the intervention. So what we wanted the interventionists to cover with patients and how we wanted them to deliver that content, that is using motivational interviewing. We standardized the training in intervention, in the intervention and the intervention delivery. And we did this through face-to-face training workshops. So we went to all the sites. One training team and the same training team went to all the sites to train them. As I mentioned, we developed a detailed intervention manual. We developed how-to videos for each session, and we conducted follow-up coaching and troubleshooting using webinars. So this is an example of the pre-session sort of summary page of the manual or the treatment guide, where we said this is the general objective of this pre-session. So again, we had a pre-session, a post-session that was individual with patients, and 4 group sessions. So the general objective of the pre-session, one-on-one with patients, was to help patients identify their health objectives and why they would consider increasing their levels of physical activity in order to achieve them. So already you can hopefully see the motivational interviewing kind of objective here. We want patients to tell us what's important to them, what they want to achieve, and we wanted them to see doing more physical activity during daily life as being one way to help them achieve it. So these are the specific objectives, the things that the interventionist had to do with the patient during that pre-session. And so this is what we wanted patients to do: in collaboration with the patient, identify their level of autonomy, physical activity, and functional limitations, identify their stage of change, their levels of motivation and confidence, and ensure proper use of, in this case, a pedometer. We didn't have the core outcome set back then. Certainly we would do accelerometry now, but we wanted to make sure that they could use the main outcome measure that we were using for physical activity. And now the objectives focus on the healthcare professional. So these are the things in terms of enactment. These are the bits of fidelity we were assessing at the level of our interventionists. So did the interventionist ask open questions to elicit true picture of their current level of physical activity? Did they use active listening and reflecting back? If a knowledge gap is suspected in a patient, did the interventionist ask permission to give information? So these were specific things that we were looking for to be able to say that our intervention was delivered as intended, not just in terms of content, but in using this motivational counseling style. These are the resources for this session and the questionnaires that were to be administered. And then we detailed the content, the interventions, the suggested questions. So again, this is quite detailed. What kinds of questions can you ask as an interventionist to assess level of autonomy, level of physical activity, and functional limitations? And we even provided some of the things we expected patients to respond, so that interventionists could kind of determine, are they on the right track? Are they getting the kinds of responses that we expect patients to provide in response to these questions? And this gets at that receipt. So this is the delivery of the intervention, and this gives interventionists a sense of, is my intervention landing? Am I getting, the engagement and the responses that I should be getting on the part of the patients to really say that my intervention is working as intended? What we also did, is we systematically recorded intervention implementation, audio recorded. And this was to verify that the content of each session was delivered, and it was delivered using an MI style. We also asked our interventionists to do self-assessments. Tell me how well you think you delivered this, this particular session. We audio recorded all the individual and group sessions, and we extracted the data by what we call a country case manager. What's that? As I mentioned, there were 8 different languages that this intervention was delivered in. So I couldn't personally listen to any audio recordings that weren't in English and French. So we needed to train intermediate people to interact with our coding scale to tell us if they actually administered the motivational communication skills as intended. And all of these were then reviewed by the global behavior modification team, which was led by me. We did ongoing coaching and feedback. So if interventionists failed the initial reviews, so in other words, we recorded everybody's individual session, and we to make sure that they were doing it right from the get-go. And if they weren't, we stopped them and we immediately gave them feedback and then reassessed them. And at the end of the trial, we also did an interventionist survey to get their feedback on the training that they received, on the monitoring that occurred during the study, and just to get any general feedback on the study design. So this is what the self-evaluation looked like. So the interventionists had to identify themselves. They had to check if they covered all the content that we wanted them to cover during the session. And if some topics were not covered or partially, explain why, and just any other things they wanted to flag. So any protocol deviations, for example, would be noted here so that we could refer back and say, wow, you know, there's a group of patients in this particular site that are doing really well compared to the rest. Well, we could go back into these assessments and go, oh, wow, the interventionist at this site gave everybody twice as much intervention. Maybe that's why they're doing so well. So this is where we wanted to record all of that so we could help in our interpretation of the results and being more valid. This is what the country case managers, and in some cases the global team, when they listened to the recordings, this is where we were looking to see if it was delivered in an MI style. So this is the content. Did they deliver the content of the Living Well program? And this is, did they deliver it using a motivational counseling style? So here you can see, you know, the content, and was it covered? Yes, no. And did they ask open versus closed questions? We wanted to see a greater ratio of open to closed questions. We wanted to see reflective listening on the tape. And if they gave information, we wanted to know that they asked permission to give it first, okay? That they didn't overload patients with too much information, and that when they gave information, they asked for feedback. So this was the way that we structured the evaluations from the global team and the country case managers to determine if it was delivered as intended, not just the content. And so the expert that was listening to the calls would say, you know, what was their overall impression of the session, and you know, was this highly satisfactory, see comments, needs improvement, see comments. So this is where we would flag any issues or problems with the MI delivery, and then we'd go back to those interventionists and give them some supplemental training. So I hope this gives you some tricks and tools to better enhance the fidelity of your interventions, both at the level of your interventionist, but also at the level of treatment receipt by patients. And I really want to thank you for your attention, and I hope you found this presentation helpful for your work. Thank you very much.